Welcome, Lade. Thank you for joining us on a video call. And today we are going to be talking about psychopathy, crime, forensic psychiatry, and your role in the Royal College of Psychiatrists.
Hello there. Hi. This is Akmal Makhdum with the Fourth Apple. And today, again, we have a very distinguished guest in our room for interview. We are speaking across the ocean online with Dr. Lade Smith, who is primarily a clinician, but in addition to being a clinician, she's also an academic at the Institute of Psychiatry in London, at the Maudsley Hospital. She's clinical director for Collaborating Centre of England. She is the presidential lead at the Royal College of Psychiatrists for Equality. So basically, in addition to being a clinician, there are many national roles that Dr. Smith has. So welcome, Dr. Smith.
Thank you for having me.
So today we are going to be talking about your plans of taking a greater role in psychiatry in a formal manner. You're also a commander of the British Empire, CBE, awarded for your extremely exemplary services to patients with mental health in England. So let's talk about very briefly what you want to do now after having achieved so many academic and clinical and reformative roles.
Well, thank you for asking, actually. It's a really good question. So what you realize when you get to a stage of, so I've been doing psychiatry for 30 years. And what's become apparent is that mental illness is so prevalent, not just in the UK, but across the world. And it affects people primarily when they are younger, and it creates problems for them that last throughout their lives if their illnesses are not treated early and treated robustly. And I think that now is the time that when you have some influence, that you influence change so that we can get better funding, so that we have parity of esteem with physical health problems, so that there is so that we can get funding to support the training and the resources that we need, so we can really help people, because we know that 75% of mental health problems arise before the age of 25, and we can treat those problems, and in many cases we can actually cure the problems. If we can treat those people, then they become adults who don't have mental problems. But if we leave it, they become adults who have relapsing, remitting problems.
So your basically main aim is to get more resources, more funding, so you can intervene early, before the age of 25, much before the age of 25, so you can provide better and more curative, I wouldn't say curative, but more early treatment, early intervention for those who will benefit from it and will benefit from greater resources. So that's your main.
That's part of it, because one of the main things we need to be able to do is to support existing mental health staff, particularly psychiatrists, to be able to do the job that we were trained to do. So psychiatrists, frankly, what's really good is that, say, for example, in the UK, we have 100% recruitment into the early stages of training. When we get to higher training, we're not quite at 100%. And unfortunately, when we get to consultant stages, we have, we've got on average 10% vacancies. And in some parts of the country, in some parts of the world, we hardly have any psychiatrists at all. And we need to be able to retain psychiatrists. And we need to be able to, and we can do that by allowing psychiatrists the time to be able to provide what are called biopsychosocial assessments, having the time to do that so they can develop therapeutic relationships, so that we can have continuity of care, because we know that those are the things that help people to get well and stay well. And it's not about curing people, but it's allowing them to be able to get into a state where they're able to achieve their potential. They're able to find work, they're able to find romantic relationships, able to have a roof over their heads, etc., able to have children, and so on.
So recruitment. So first one was greater funding, greater resources. Second one was uh, trying to get 100% vacancy filling in psychiatry, at least in England, where your presence and remit is. Obviously, there's very little one can do about the world. Now, I would like to actually focus on this, that why is this different for Lade Smith and for not anybody else? So what does Lade Smith bring to this particular role? This is a very generic uh, thing, more resources, more recruitment. Everybody's saying that. So where does Lade fit in? That particular spice that you bring in?
Sure. So clearly it's not just recruitment, it's retention that's most important for me, actually. Because we, as I've said, we've got we're doing pretty well with recruitment, but it's retention. The difference is that I've actually worked in so many different fields in psychiatry. So in general adult trained, worked in forensic psychiatry and rehabilitation psychiatry, I've done addictions, I've done a number of different fields. I'm also a researcher, educator, clinician. I'm a clinician manager, and very importantly, I'm a policy maker, and I've also developed systems to implement policy and actually work with those. So, for example, there's an advancing mental health equality strategy that's now been adopted by NHS England and is actually being disseminated across the UK. And not just in England, actually. There's the patient and carer race equality framework, again, something that I was involved in developing. It's been disseminated now it's being piloted in 4 sites, and that is across England. There's the community mental health transformation work that has been disseminated, and also there's mental health act reforms. Now, the important thing is in that all the work I've been doing over the last 30 years has meant that I have developed relationships with people, all the various key stakeholders in the mental health world, and really importantly, have actually sat down with the decision makers, not just the commissioners, but the decision makers in the Department of Health, in the top levels of the NHS, and actually been able to persuade them, because we've got the evidence, and the evidence is really strong, that they need to be resourcing and supporting mental health care. And I've been able to do that, and I am able to hit the ground running with that, actually, in a way that perhaps other people aren't able to do, because they don't already have those connections. They don't have they haven't learned necessarily yet how to influence people, not simply with the evidence, the quantitative evidence, but also the qualitative evidence. The stories are really important too, and you have to be able to get in there and talk to these people. But just to add, actually, the other things that are really important is being able to support people on the ground. And I think there's been a big problem, we know that, for example, with the Royal College of Psychiatrists, only about 20 or 25% of psychiatrists actually engage with the college. And that's because they feel that the Royal College of Psychiatrists doesn't really it's not very relevant to their everyday work, or it doesn't really represent their views. And I very much understand that, being someone who, has been in that position myself, actually.
Okay. So, that's thank you very much, because that was going to be my next question. In terms of relevance of the Royal College, so could you give me, in like bullet points, 3 main priorities of making the Royal College of Psychiatrists relevant? So far, you've talked about people in general, people who need mental health services. You haven't really addressed the need of psychiatrists. Obviously, somehow, greater resources may mean some of the needs being met, but that is not really addressing psychiatrists' needs. So you want to become the biggest representative, the top psychiatrist in England, and one of the top psychiatrists in the world, being you want to become the president of the Royal College of Psychiatrists. So what are you going to do about psychiatrists?
So I think first thing to say is this, actually. Do you know what I want, really? What I want is for psychiatrists to be able to thrive in their work. It happens to be that one way of doing that is to become the Royal College president so that I can support psychiatrists to do that. For psychiatrists to be able to thrive in their work, we need the following. We need to be given the mechanisms to address the treatment gap. It is incredibly demoralizing when you have patients, you get them better, you send them back to the kind of situations that actually make them ill in the first place. There was a lack of understanding of the impact of social determinants on people's mental health, and we now know that 20 to 30% of the ill health that we see is driven by people's social situation. So there has to be someone who is going to be able to talk to that very clearly and eloquently and have the evidence in the right spaces at the right time. I can definitely do that. That's number one. And that will make a difference, because if we can persuade the commissioners to commission the services differently, even with the current spending envelope that they have, but they can decide what they can choose what they spend their money on, and we can influence that very strongly. And in fact, one of the things that I was involved in developing was a college engagement network, supporting psychiatrists to learn how to influence their regional commissioners. And that's something that I would drive very strongly, actually. So it's building up psychiatrists. Second thing is, I'm really very keen, and you'll see in my presidential priorities, that we raise the profile of psychiatrists actually as doctors. We are the doctors who have, we understand the science, the neuroscience, we understand the social science, we understand the physical health needs of that people have. We understand the longitudinal aspects of their histories, the depth and the breadth. We can understand the complexity. There's no other profession that can do that. And I think one of the issues is that we're very nice doctors, psychiatrists, and we don't necessarily make a big fuss and bother about what we can do and how varied and interesting the work is that we do. But I think I am someone who is able to speak to that very strongly, because I'm very passionate that being a psychiatrist is actually the best kind of doctor you can be. You are a doctor who can understand all of the different things I've mentioned, the complexity, a doctor who can understand the science and translate that. And we should be shouting that loudly and proudly. And I think it's really important for psychiatrists to be able to stand up proudly and say, we do a really important and good job, because that will also go some way to helping our patients and helping commissioners and the decision makers to understand how important it is that they support us in that. And then the final thing I very much feel is fairness for all, and that's not just for patients, and we know, as mentioned, about health inequalities already to some extent, but also for doctors within mental health care. And it's absolutely crucial that psychiatrists are treated fairly so that they can thrive in their jobs, so that they can progress in their careers. And we know already that there isn't fairness for everybody in mental health care. It depends. For example, we know when it comes to exams that there's significant differential attainment, and the GMC and the BMA have admitted that actually the biggest difference to whether or not you pass your exam is not your academic ability, it's your ethnicity. We know that the biggest difference when it comes to career progression is not your academic ability, it's your ethnicity. To the extent that there's even, not only is a slowing of career, you have delayed career progression, there's even an ethnicity pay gap. Now that is not fair. And that's something that I can make a difference to, have already started to make a difference to, and will continue to make a difference to.
How will you do that?
So,
how do you try to get the ethnicity? I mean, let's translate ethnicity. It's a very kind of, amorphous term. So you mean the color of your skin, the language, so your, yeah. So let's simplify it for the reader or the listener. Okay. That is the color of your skin. So how are you going to be tangibly doing that within 3 years or whatever years that you'll have if you get elected?
Okay, so I was just to add it, so colour of your skin, your accent seems to make a difference, and your culture actually. So, just to let people know, the listener, that I've already started doing this. So in our work as in the Joint Lead for Equality at the Royal College of Psychiatrists, we've already developed systems. So I mentioned the Advancing Mental Health Equality work. Now, that in and of itself is work that it's a system that addresses, tries to improve access and experience and outcomes for patients. You can use a very similar approach for staff too. And so what we've also been doing, and that's already been disseminated, what we've also been doing is actually developing some guidance around tackling racism in the workplace. And that's something that we started some time ago. It will involve not only support for the employers, but also employees, employees who may have experienced discrimination, but also employees who may have witnessed discrimination. And that includes understanding what it looks like, the legal ramifications, what your rights are, and what the employer is expected to do. Also, some guidance around how to improve things and positive practice examples, because some people actually tackle this pretty well, and some people, some employees as well as employers have managed to start improving things. So it includes a decision tool, so it helps you to recognize when there are problems and what you can do to tackle those problems. The other aspect of it is, and very importantly, when it comes to exams, for example, we know that we've worked with the chief examiner, Ian Hall, and and you can even look on the website now to see what they've done with the exams to try and make the exams more accessible and a little bit more equitable, and that started. Then you can look at the it's interesting. The written exams, there's been quite an improvement actually in the written exams. So the level of attainment is leveled out, but we still find that there are ongoing problems with the CASC. That's the clinical exam, which is evaluated face to face. So that means that more needs to be done to more needs to be done to stop that differential attainment at the clinical exam stage. There's a woman called Catherine Wolfe. She's an academic at University College London, and she's done a great deal of work in this area. And what she has found is that it's not academic ability that interferes with people getting on, but what tends to happen is that the kind of support that people need an earlier stage to be able to, before they start doing the exams, they don't quite get the same learning opportunities. And it's very interesting because a similar thing happens with work. So people at work, in order to progress in your career. So Roger Klein looked at this, and he was, when you ask senior executives and senior directors what is it that helped them to get on in their careers, that 70% talk about 70% will say, well, actually it was probably the stretch opportunities, learning on the job, being supported and given additional responsibilities at work. So 70% have said, 70% of senior directors and executives have said, look, it's learning on the job, the stretch opportunities. That means the aspects of given additional responsibilities in those jobs and being supported and expected to do that. 20% is learning from mentors and coaches, and only 10% is actual formal mandatory learning. Now, we all have access to formal mandatory learning. If we're lucky, 20% of us will get access to mentors and learning sets. But what you don't get, and you're less likely to get, unless there's a formal system, what you're less likely to get if you are from a minoritized ethnic background, if you're brown or black, or you have an accent, you're less likely to be offered those so-called stretch opportunities, those additional responsibilities and so on, unless you know someone and they tap you on the shoulder. The problem with that tapping on the shoulder is you're less likely to get tapped on the shoulder if you're not like the majority people in the room.
To more tangible or steps. General Medical Council has been exposed time and again through statistics, through anecdotes, through narratives, through suicides, through heart attacks, through destruction of life and careers and so on. And basically, there doesn't seem to be any tangible change. at least in the 40 years that I've been, working in psychiatry until I worked in psychiatry. Now, how are you going to deal with the General Medical Council and the psychiatrist in particular?
So one of the things that has happened, particularly this year, is I think the General Medical Council have had to start recognising that they have got an institutional problem. And one of the difficulties that I think people mistake over interpersonal discrimination for institutional and structural discrimination. These two things are different. So when you say to someone, but that's discriminatory behavior, they'll say, no, it's not. I didn't call them a name. I didn't, hit them because they were a brown person or a black person. I didn't do anything like that. So they think they're okay. And I think the GMC, until very recently, have denied the discriminatory aspects of what they do. More recently, it's become very clear through all the evidence, and that's why you need the evidence. Actually, you need the data. The data is clear. If the GMC has got an institutional and it's got a systemic problem. The head of the GMC, Charlie Massey, appears to have recognised this, and
Why did he do that? Sorry for interruption. Did he make that statement publicly that yes,
actually,
we
he
are a
did.
racist organization?
Well, I don't think it's quite said they're a racist organisation, but it said there
No.
are definitely is accepted that there's differences in referral rates, etc. And interestingly, what the GMC did recently is I think they maybe took a leaf out of our book and they produced some guidance online about tackling racism in the workplace, because they recognise that there's another problem is that you're far more likely to be referred to the GMC if you are a minoritized ethnic doctor than if you are a white British doctor, for example. And particularly if you are an internationally trained medical graduate in the UK. And they've recognised that, and they've actually put out some guidance on that. What I would do, we're doing this anyway, that we're developed and developing this guidance on how to tackle discrimination in the workplace. The college has massive influence, and psychiatrists if you're a minoritized ethnic doctor and you're a psychiatrist and you're internationally trained, you're much more likely to be referred to a GMC. And the college should be working with the GMC and saying, hold on, this is not acceptable. Also, not only is it not acceptable, this is what you can do about it. And this is about working with workplaces to reduce the likelihood of people being referred for what are sometimes spurious reasons. When people are referred to the GMC, there really needs to be training and guidance for the middle managers at the GMC, who, for some reason, it seems, and I think it's probably to do with a person's name or whatever, that they are much more likely to pass that person on. The individuals themselves I've seen this, they do not get the support that other doctors would get when they are referred to GMC. And actually the GMC should have a package of support and care, and the college can provide a package of support and care to support through the psychiatrist support service to reduce the likelihood of people who are going through that who find themselves in that invidious situation of being referred to the GMC, reducing the likelihood of them harming themselves or committing suicide, or dying by suicide, which is what happens to doctors at the moment.
Yeah. If I could come here, I mean, what you're suggesting is, and do correct me if I'm not understanding it, is that you want to reform the racial and discriminatory behaviors in the GMC through the various hints that people have been suggesting that, oh yeah, we may have a problem, we have a problem, we want to do something about it, let's train something. Racism hasn't really gone out of any society for a few hundred years. I mean, do you want to say that you want to make through colleges training programs a non-racist GMC?
Actually, I didn't say that through the training programs we're going to make organizations, not races. What I said is that, and this is what we know. If you the fact is that racism is an unconscious process. Racism and discrimination is unconscious, and with the best will in the world, people might try their hardest not to be, but they don't realize they're doing it because it's unconscious. What you do is you change the processes, the policies, and the procedures. So it doesn't matter what an individual's unconscious bias will be. The processes and the procedures and the policies are designed such that actually people can't be disadvantaged just because of the color of their skin, or because of the accent they have, or because of where they trained. And so what
What
you
will the
do is
college
you
do?
develop. Well, the college is already doing some of this.
You as the president,
Yes.
what will you do?
So I've already started this work, as I've said. So the system, this is when I'm talking about the systems we're putting in place, the systems that we have developed already and have already been instituted across the country, not just simply England, but across the UK, already are equity delivery systems. So we've done this, and we're working with the CQC and the Equality and Human Rights Commission, who are actually taking this. They are expecting now to see this equity delivery system in place in organisations, and that similar thing can happen. The college can support the GMC to institute a similar equity delivery system, which is what has started at the college as well. So it's not saying, how do you begin to do it? I'm already doing it. And it's really about disseminating that work more widely, because we can see that that work is starting to make some gains. No, it's not going to eliminate racism from society. It's not going to eliminate discrimination from society, but it will reduce the impact of that discrimination on minoritized ethnic doctors.
So, okay, what about this idea that has been floated and discussed is that the Royal College of Psychiatrists takes an independent, professional, and ethical and moral view on each psychiatrist who's referred to the General Medical Council, not interfering directly, but as the body representing and being constituted by psychiatrists becomes more relevant, and says 7 psychiatrists have been referred to the General Medical Council. 7 particular teams are being constituted by the Royal College, and they are going to be looking at and making an independent clinical and an ethical view on these cases, regardless of what the GMC's role is or what their procedures are. What do you think about that?
That's an interesting idea. It's an interesting idea. I have to say that one of the things that I was really struck by in the last year was how decisions that are made by the college have really felt by the members to have been made very kind of unilaterally, without consultation, without discussion, and has only served, I think, to alienate people on the ground. And I think that this idea sounds really interesting. It's a kind of idea that I think you should put to psychiatrists and say, what do you think of this? How would we like it to look? So that everybody knows about it, and everyone can contribute it, and actually make it something that would be, if people want it to happen, make it so that it becomes something that's much more robust, far better thought through, and that if everyone's on board with, then you're much more likely to get people who are going to support the delivery of something like that, actually. And it would also give a much better mandate to be able to say to GMC, we're doing this, and it's actually supportive of you, because you've got an additional overview as well, if that were to happen. But that's something that I think we should be talking to the members about, to say, what do you think of this kind of idea?
Well, I hope that you add that to your to-do list, please, because I'm sure that there'll be unanimous support and universal support that the professional body to which all psychiatrists want to belong and do belong, at least in England and Wales and Anglophone countries, maybe except US or Canada. So if they know that professional body that examines them and sets those standards of clinical and ethical work is having an independent view on their case, which is being independently and not overlap or discuss with the General Medical Council. because that would be influencing the council, the
Mm.
GMC. Let the GMC run their course, and you as the college, do an independent review and have a supportive, reformative, remedial, or punitive, whatever the case may be, depending on what the peers decide. Like in a jury, there are the 12 peers who
Yeah.
decide how long, or you're guilty or not. So that's what this is something that has been proposed and suggested. So, Dr. Lade Smith, indeed a pleasure. It was excellent to have you here, and we wish you the best of luck in your future endeavors and carry on the great work. Thank you very much.
Thank you very much for having me. And I wish you all much health for the coming year, and much health and wealth and prosperity and happiness. Thank you.
Thank you. Yeah. Thank you very much. So, viewers, we had Dr. Lade Smith on the Fourth Apple. So we'll see you again. And from me, Akmal Makhdum, goodbye.